at the time of recording, you announced last week a $150 million Series C raise, which follows just 4 months behind a $40 million Series B raise. That to me is almost unheard of, that kind of rapid growth. And so it's a testament to what you guys are doing at Abridge. Super, super exciting. You are both the Chief Technology Officer, the CTO, and the Chief Science Officer, CSO at Abridge. And the idea is that it's a AI platform for clinical conversation. Do you want to fill us in on kind of a high level to start on what you guys are up to at Abridge?
Sure. I suppose it's always the really broad view, which will sound like crazy and maniacal, and like our plan is to do anything and everything at the intersection of AI and healthcare. And then there's like a really narrow view that sort of speaks to the particular use case that we've unlocked and kind of flagship product that's hitting the market right now. Um, at the broadest view, I think just my entire career in machine learning, before I was a professor of machine learning at Carnegie Mellon, before I was a PhD student at UCSD, comes from being a patient and being caught in one of like the grayer areas of the health system where people are not sure how to help you, and where patients kind of have to dig through and figure out what's going on themselves. And I think there's like you start looking around, you see things like there's diseases where you've got tens or hundreds of thousands or millions of people who are affected, and people are publishing studies based on 40 cases. And just like our use of information to inform care, to constitute like empirical foundation of healthcare is such it's just like nothing compared to what it could be, compared to what's technologically possible today. And like that was why I went into PhD, not because I was an expert in machine learning, but because I had a feeling that this was how we're going to advance medicine, or at least the way that I was maybe set up to be, given that I wasn't a doctor, I hadn't gone to med school. And I think my entire research career has been sort of a combination of doing medical collaborations and stepping back to try to think what are the fundamental technologies that we need to make it all possible. Um, there's the narrow view, and the narrow view is basically there's a crisis happening right now in healthcare. That crisis is basically that we have more and more patients every year. The population is growing, and the number of doctors is shrinking. And the biggest cause of this is physician burnout. So we have a bunch of decisions, all of which independently make a lot of sense. Like we move doctors over from writing health records and writing notes on dead trees and putting them in filing cabinets, which seems like that can't be the way of the future, to modernizing the health system and putting everyone on digital medical records. Um, we also said, well, patients should have some amount of right to see what's going on in their records. And while we're at it, other stakeholders in the health system should be able to see records, including payers. Um, and then we start going through and saying, oh, there's all these other things that should also be documented. And since we have the health record, why don't we add fields for those? And they all independently make sense. Like if there's informed consent as part of the visit, that should be documented separately. Billing code should be registered somewhere in the record. But what it's all added up to is a situation where these things all make sense, and we kind of need and want all of them, but it's created a clerical burden on the provider, where the doctor right now, for example, or other clinicians are spending 2 hours doing like clerical scut work for every 1 hour of direct care. So it's sort of a like, would you like some fries with your ketchup situation? Mostly like they're treating the paperwork and sometimes getting to spend face time with the patient. I don't know, it reminds me of a situation in data science and machine learning that you think like you're going into machine learning and you get to do cool modeling, cool algorithms, then you spend all of your time cleaning data. They're there to treat the patient, but they're spending all the time like mucking around in the health record. And the big insight that our founder Shiv had from the very beginning, when he approached me back at the sort of the beginning of the founding of Abridge, was that sort of all of this work, upstream of all of it, like the primary source of truth for almost all of these downstream decisions, upstream of all the documentation, the rev cycle work, the diagnostics, the therapeutics, the referral letters, um, clinical trial matching, like upstream of all of that is a conversation between a doctor and patient. Like this is like the primary source of information, the primary like location of decision making, and almost everything takes place within the doctor patient conversation. If only you could sort of tap into that conversation, you get to like unlock all the tooling that could reduce the pain of these downstream workflows. So the realization that, if you had an assistant sitting in the room, just taking notes who just broadly was like medically knowledgeable, they'd be able to get you to a first draft of a note that was maybe 95% of the way there. There might be a few things that the doctor had in their head or some pieces of prior context that they needed to add to the note that weren't actually vocalized during the visit, things they forgot to say out loud. But really, like the vast majority of the information that you need to make this work happen is context that was already given. And the decisions have already been made. The treatment decisions have already been made. The referral decisions have already been made. The diagnostics have often already been spoken aloud. It's really so much of the work here is just taking this information and sort of remixing it, reconfiguring it, pulling out what is the part that pertains to the history of present illness, what pertains to the assessment and plan, what pertains to the medication list. And so that we could go based on that conversation and go from there end to end all the way to a first draft of a note that's ready for a doctor's review. So we take a doctor, and instead of their job being to like sit and like have to, after the visit, they're kind of burnt out, they're seeing, they've already done this 15 times that day, and they have to like first start typing up like 2 pages of documentation from scratch. They get a running start. They get to start off with the core note is already written, and their job is to check, are all the important pieces there, add anything that's missing, verify the content if they have any doubts. And we provide this end-to-end experience, everything from the raw audio through the transcription, through the sort of sorting and structuring of content to where it belongs in the note, the abstractive summarization. And then we don't see our job as ending when the draft is there. We pick up the job on the other end and provide these assistive editing tools. For example, a doctor can highlight any piece of text, like a word or a sentence or even a couple sentences, and float immediately to where in the transcript is the substantiating evidence that backs that up. And if they don't see it, that's funny, Apple balloons showing up. If they don't see the evidence, then they have a basis for either doubting what they see in the note. But 99% of the time, they get right to the evidence, and they could click on it and immediately even hear the audio playback from precisely that part of the conversation where that content came from. So we build a level of trust because it's a level of trust that comes almost from not having to trust us, not having to take our word for it. We direct you. We have a certain stewardship for the provenance of information. We take you all the way back to the source. People think that AI could have a propensity to hallucinate, but nobody's worried that microphones hallucinate, and that's the essential character of the product.
It's amazing. And I can see how it would be such a transformative tool for a doctor to wield to allow them to get that 2-to-1 ratio of administration to patient care down and to ultimately be able to see more patients, have less burnout. Also, presumably, improve outcomes by having such rich data from the conversation, easily summarized, easily being able to look up from those conversations as opposed to having to dig through them. When a physician is using this tool in a hospital setting, do you provide them with a particular kind of hardware to be working with, or does it works with the hardware that they already have?
Yeah, and no special microphone required. We can record from like sort of multiple sources. We could do web recording, like we could record from the app interface, like on the desktop, but we could also the primary way that people use it is that they have an app that functions as a recorder. So on their work phone, they have the Abridge app. The app is synchronized. So we're another characteristic of Abridge that as much as like my tendency as like AI scientist is to like focus entirely on the technical guts on the like deep learning level. There's a tremendous amount of work that we've done in terms of our integration into the workflow and into the health system. So we have a partnership with Epic, and we are integrated into the electronic health record. So the patient, when they pull it up, will actually be able to pull their entire, the provider, the doctor or nurse, when they pull up the app, they'll actually see their schedule for the day, and so they can click into the appropriate encounter and start recording. And at the end, when they hit complete note, what's going to happen is Abridge is going to run in the background. It's already transcribed all the audio. It's going to generate the appropriate note, and it's going to beam it right into the medical record um, for the corresponding patient against whom they were recording. And then when they open it in the health record, then they have a set of tools for editing the final note and ultimately finalizing and signing it.